Do you wake up in the morning and find that you are constantly dropping your coffee cup because your fingers feel thick, numb, and clumsy? Or perhaps your upper body is fine, but after standing for just 10 minutes, your lower back locks up like a rusted hinge and a burning electrical pain shoots down the back of your thigh. Have you experienced a sudden, terrifying sensation where your leg simply gives out beneath you, causing you to stumble? If you check these boxes, your central nervous system is sending out a massive distress signal. You are not suffering from carpal tunnel syndrome, and your hip joint is not failing. You are experiencing the severe neurological consequences of degenerative disc disease. But the symptoms vary wildly depending on exactly where the mechanical failure is happening. Today, we are going to decode your symptoms and map exactly how a dying disc in your neck acts entirely differently than a dying disc in your lower back. To understand your symptoms, you must understand the two very different engineering jobs your spine has to perform. Your lumbar spine, which is your lower back, is engineered like the base of a heavy-duty industrial crane. The lumbar spinal discs are massive, thick, hydraulic shock absorbers. Their primary job is to carry the entire vertical weight of your torso, head, and arms and transfer that massive mechanical load smoothly into your pelvis and legs. Because they carry so much weight, lumbar discs are highly susceptible to pressure-based degeneration and collapse. Your cervical spine, which is your neck, has a completely different job. It is engineered like a high-precision robotic arm. The cervical spinal discs are much smaller and thinner. Their primary job is to support the weight of your skull while allowing for an extreme range of motion, looking up, looking down, and rotating side to side. Because the cervical spine is so mobile, its discs are highly susceptible to rotational wear and tear. When the rubbery wall of a cervical disc dries out and degenerates, the excessive micromotion causes the surrounding bones to grind together rapidly. This anatomical difference leads to a massive, dangerous trap in standard medical clinics. When a dying spinal disc collapses, it loses its height. The bones move closer together, which narrows the small bony tunnels where your nerve roots exit the spine. If the disc bulges or a bone spur grows into that tunnel, it acts like a physical clamp on the nerve cable. The hidden danger is that your brain is easily fooled by where the pain is coming from. If a nerve is clamped in your neck, the pain signal travels down the entire length of the cable and registers in your hand. If a nerve is clamped in your lower back, the pain signal registers in your calf or your foot. Millions of patients undergo unnecessary wrist surgeries for numbness or get painful steroid injections in their hips for burning pain simply because their local doctor treated the end of the nerve cable instead of looking at the spinal breaker box where the actual damage is occurring. You must trace the wiring back to the source. Let us decode the specific warning signs of cervical degenerative disc disease. The most common symptom is a low-grade, stiff ache in the back of the neck that worsens when you look down at a phone or a computer screen for extended periods. This is the mechanical pain of the dying disc itself. But as the disc collapses and the facet joints begin to grind, you enter the neurological phase. If the degenerated disc pushes against a cervical nerve root, you will develop cervical radiculopathy. This is characterized by sharp, stabbing, or hot electrical pain that radiates from your shoulder, down your bicep, and into your hand. The exact finger that goes numb tells us exactly which disc is failing. If your thumb and index finger are numb, the C5-C6 disc is collapsing. If your middle finger is numb, the C6-C7 disc is the culprit. You may also experience severe muscle spasms in your upper back and shoulders as your body violently tries to lock the unstable neck in place. Now let us shift to the heavy-duty crane, the lower back. The baseline symptom of lumbar degenerative disc disease is a continuous, dull ache across the lower back that occasionally flares up into severe, paralyzing pain. Because the lumbar spine bears so much weight, the pain is heavily dictated by gravity and posture. Sitting in a chair compresses the dying lumbar discs, significantly increasing the pain. Walking or changing positions relieves the pressure on the disc and transfers it to the muscles, which usually provides temporary relief. When a lumbar disc collapses and pinches a nerve, you develop lumbar radiculopathy, commonly known as sciatica. You will feel a searing, lightning-like pain shooting through your buttock, down the back of your thigh, and sometimes into your foot. The most alarming symptom of lumbar degeneration is the giving out sensation. As the disc loses its internal pressure, the spinal segment becomes mechanically unstable. When you make a sudden movement, the vertebrae shift abnormally, causing a rapid protective muscle spasm that makes your legs feel like they are collapsing beneath you. To fix these symptoms, we cannot rely on guesswork or a simple physical exam. We must use a high-definition magnetic resonance imaging scan to evaluate the specific type of compression occurring inside the spinal column. We are looking for two very distinct clinical scenarios: radiculopathy versus myelopathy. Radiculopathy means a single nerve root is being crushed as it tries to exit the side of the spine. This causes the localized arm or leg pain we just discussed. Myelopathy is a much more severe, life-altering condition. As discs degenerate and massive bone spurs grow, they can push backward into the main central canal, actively crushing the spinal cord itself. Cervical myelopathy causes your hands to become clumsy, making it difficult to button a shirt or hold a pen. It causes your legs to feel stiff and uncoordinated, leading to a robotic, stumbling walk. Severe compression of the spinal cord is a neurosurgical emergency. We use the MRI to measure the exact millimeters of fluid space left around the spinal cord to determine if permanent paralysis is imminent. Because the symptoms of disc degeneration perfectly mimic so many other joint problems, the treatment protocol must be ruthlessly precise. We do not apply generic therapies. If the MRI proves that your numb hand is caused by a contained cervical disc bulge, we bypass your wrist entirely. We target the neck. We use advanced, minimally invasive techniques like percutaneous laser disc decompression. We insert a microscopic laser fiber directly into the dying cervical disc, vaporizing a tiny amount of the internal tissue. This creates a vacuum, pulling the bulge away from the nerve root. The blood flow returns to the nerve and the feeling in your hand is restored. If the MRI shows that a collapsed lumbar disc has caused massive bone spurs to grow and choke your spinal nerves, a laser will not work. We must mechanically widen the tunnel. We use specialized endoscopic tools through a tiny keyhole incision to gently shave away the overgrown bone, physically freeing the trapped sciatic nerve without cutting through the major stabilizing muscles of your lower back. If your hands are constantly numb or your legs feel heavy and painful, do not let anyone operate on your limbs until they have thoroughly examined your spine. You must identify the true mechanical source of the short circuit. Stop treating the symptoms blindly. Let our expert neurosurgeons review your medical imaging. Click the link in the description to upload your MRI or CT scans to our secure portal. We will map the electrical pathways from your spine to your extremities, give you a definitive second opinion, and build a targeted plan to release the pressure on your nervous system.